Good afternoon, our professors, our colleagues. It's my pleasure to introduce one of my lifetime dear colleagues, astonishing doctor, Professor Dr. Amira Dia, and her presentation moving forward the management of advanced hair, positive hormonal positive, HER2 negative, breast advanced HER2 positive, HER2 negative breast cancer.
Oh, okay. Assalamu alaikum. My talk will be moving forward in the treatment of hormone receptor positive HER2 negative breast cancer. Hormone receptor positive HER2 breast cancer comprise about 60 to 70% of all breast cancer. 30% of those initially treated with endocrine treatment for early stage will relapse with metastatic spread. And hence endocrine treatment in the metastatic setting have a main role in maintaining disease control, delaying the need for chemotherapy and preserving quality of life. However, despite the efficacy of these drugs, resistance to endocrine treatment remains a key clinical challenge. Hence, a logical approach is to block both pathways, the endocrine pathway and the escape pathway. This cartoon shows most of the mechanism of endocrine resistance and the target drugs in order to overcome them. Upon stimulation of the estrogen receptor by the endocrine treatment, various pathway escape mechanisms occur, such as alteration of cell survival and cell cycle pathway. Key pointer. Alteration of cell cycle survival pathway by amplification of cyclin D1, the activation of the growth pathway in the PAM pathway PK3 AKT-mTOR inhibitor, and lastly, activating mutation in the estrogen receptor. According to the ABC and the ESMO and the ASCO and NCCN guidelines, the preferred first-line regimen for hormone receptor positive HER2 negative metastatic breast cancer includes a CDK4/6 inhibitor in combination with endocrine treatment. It has been now more than 6 years or around 8 years upon approval of the first CDK4/6 inhibitor. We have 3 drugs available in the market. All are effective, but all are expensive and all reasonably well tolerated. Here, the difference between the 3 drugs are they all have the same dosing, oral dosing, with palbociclib, ribociclib taken once 3 weeks on and 1 week off, while the abemaciclib is taken twice daily continuously. The most common side effect with the abemaciclib is the GIT symptoms, while the ribociclib and palbociclib mostly is complicated by bone marrow suppression. This diagram shows that trials of the CDK4/6 inhibitors in combination with endocrine treatment in the first and second line trend. On the left side, these are trials of the first line. All are big trials. All have good overall response, and most of them and all of them showed improvement in progression-free survival. This is a Kaplan-Meier curve of the 3 trials, the Paloma 2, the Mona Lisa 2, and the Monarch, of the palbociclib, ribociclib, and the abemaciclib. And if we remove the name of the trials, we found that all the trials showed a marvelous response in progression-free, median progression-free survival. In the ASCO 22 this year, the updated result of Mona Lisa 7 showed that there is an overall survival benefit with the addition of ribociclib with the endocrine treatment, and also in the premenopausal women who use tamoxifen, also there is an improvement in overall survival. However, although it's effective, there is resistance to CDK4/6 inhibitor in around 20% of the patient. Resistance ought to include cyclin E amplification, retinoblastoma loss, and cyclin D4 overexpression, or the upregulation of the P3K AKT pathway. Then what to do after progression? The optimal treatment is either we switch or to maintain. Like in the HER2 positive disease, sometimes after progression on HER2 positive breast cancer, we maintain the anti-HER2 target agent. There is a logical thinking of continuing the anti-CDK4/6 inhibitor. So we can switch the endocrine treatment and maintain the CDK4/6 inhibitor. We can maintain the the endocrine treatment and we can maintain the CDK4/6 and switch to another endocrine treatment, or we can maintain both and target a collateral pathway. The maintain trial addressed this issue in case of they will switch the endocrine treatment and maintain the CDK4/6 inhibitor. And here an improvement in progression-free survival in patients who receive ribociclib with endocrine treatment switch, and also subgroup analysis according to the ESR mutation, those with mutant and wild type. Those with mutant showed a better progression-free survival than those with non-mutant wild type ESR mutation. Hence, there is upcoming trial, randomized trial, the Palmyra and the post-Monarch trial, addressing the issue of maintaining the CDK4/6 inhibitor with either fulvestrant, letrozole, or with tamoxifen. The second pathway that we can inhibit in order to regain the endocrine sensitivity is targeting the P3K/AKT/mTOR pathway. The activity of the mTOR inhibitor was first approved before the development of the CDK4 inhibitor. And here the Bolero trial showing that everolimus added to exemestane have an improvement in progression-free survival. And we found that there is an improvement of 5 months in median progression-free survival in the everolimus exemestane group. Another trial, the TAMRAD and the pre-EOCOC trial, are showing the addition of everolimus to tamoxifen and fulvestrant. However, there is no result from prospective trials found nowadays about using the mTOR inhibitor after failure of the CDK4/6 inhibitor. These trials was before the introduction of the CDK4/6 inhibitor. Targeting the AKT pathway by the alpelisib have been approved by the FDA after the result of the SOLAR trial, with addition of alpelisib to fulvestrant in postmenopausal women who progressed on or recurred after primary aromatase inhibitor therapy, and one line of chemotherapy is applied. Patient are subgroup of the patient are divided according to whether there is P3K mutation or no mutant, and they are divided into group who receive the alpelisib with fulvestrant versus placebo and fulvestrant in the P3K mutant, and another group who receive it without finding a PK3CA mutant. Here is the Kaplan-Meier of the progression-free survival and overall survival. We found that there is improvement in progression-free survival with the alpelisib with fulvestrant, and the overall survival didn't reach the point that that was found in the trial. Subgroup analysis they contain a group who received the prior CDK4/6 inhibitor, and this group was only of small number, 30 patients only, who have prior CDK4/6 inhibitor, and we found from the curve that there is improvement with the addition of alpelisib to fulvestrant in those who progressed on CDK4/6 inhibitor. And those also who didn't receive CDK4/6 inhibitor, there is also improvement in progression-free survival. Median overall survival was prolonged by 14 months for patients who have P3K mutant. Activity with PEAK3 and various endocrine treatment in the second-line setting after CDK4/6 inhibitor is addressed in the BYLieve study, where they include a cohort of patients who have CDK4/6 with aromatase inhibitor as immediate prior treatment, and a group who received CDK4/6 with fulvestrant, and a group who was treated with chemotherapy or endocrine treatment. Another target is the capivasertib, who, although it doesn't achieve the FDA approval, however, it gets a good results in the FACTION trial, randomized phase 2 study studying the capivasertib with fulvestrant versus placebo in postmenopausal women with hormone receptor positive HER2 negative after relapse or progression on AI. Capivasertib improved the progression-free survival and overall survival in endocrine-resistant patients. And here is the Kaplan-Meier curve showing improvement in both the progression-free survival and overall survival. Upon subgrouping of the patient who received the capivasertib, those with mutant altered pathway and those who doesn't have an alteration in the PAM pathway, we found that there is a significant improvement in the median progression-free survival on those who have alteration in the mutant. Key ongoing phase 3 trial of capivasertib with fulvestrant is the Capitello phase 3 trial with Capitello 291 studying capivasertib with fulvestrant versus placebo, and Capitello 292 studying capivasertib, 2 palbociclib, and fulvestrant. Other compound that can be used to overcome the endocrine resistance is the elacestrant, which is an oral selective estrogen receptor degrader. However, the result from this trial didn't reach the point of significance, and hence it didn't gain the FDA approval, although there is a mild improvement in reduction in the risk of progression in all patients. However, the Emerald, as seen here by the Emerald trial, in patients who have previous endocrine treatment and previous CDK4/6 inhibitor, patients who are harboring the ESR1 mutation have better reduction in the risk of progression than those who didn't receive it. Considering the anti-TROP2 antibody drug conjugate, sacituzumab govitecan is an anti-TROP2 approved by the FDA for triple-negative metastatic breast cancer after 2 previous therapy based on the ASCENT trial. It showed these drugs can be used in hormone receptor HER2-negative breast patient in adding to the after progression on various lines of chemotherapy, Taxol-containing or endocrine treatment, and it showed a significant improvement in progression-free survival, and the results of the TROPICS-2 trial have been published nowadays recently in the ASCO 2022. The TROPICS trial have showed that according to the, there is a 34% reduction in the risk of disease progression with sacituzumab govitecan, with higher patient alive and progression-free by this study at 6, 9, and 12 months. Additional target that can be used in hormone receptor positive HER2 negative is the PARP inhibitor. Based on the result of the phase 2 trial, Olympia trial and Baraka trial, the two approved PARP inhibitor, olaparib and talazoparib, are included as category 1 preferred option for those with germline BRCA1 or 2 mutation. There is a significant improvement in progression-free survival in those receiving PARP inhibitor. Other drug that can be used is a neurotropic tyrosine kinase inhibitor, the lalotrectinib and entrectinib. They are FDA approved for treatment of solid tumor that have NTRK gene fusion without known acquired resistance and who have no satisfactory alternative treatment or have progressed following treatment. If patient with stage 4 breast with a tumor with an ATRK fusion gene, treatment with NTRK inhibitor is an option if no satisfactory alternative treatment exists or have progressed following treatment. Pembrolizumab is FDA approved for patients for solid tumor who have high mismatch, high or deficient mismatch repair gene, microsatellite instability high or deficient mismatch repair gene. Patient with metastatic breast whose disease have progressed following prior treatment, pembrolizumab can be added to their treatment. Last but not least, still we can consider the use of hormone treatment, either AR aromatase inhibitor or tamoxifen, is a valid option as first-line endocrine treatment for selected patients, particularly in tumor characterized by endocrine sensitivity. The median progression-free survival increased from 6 to 9 months in earlier trial to 13 to 16 months in the current era without the addition of any other drugs. Single agent fulvestrant also, per the result of FALCON trial, show increase in progression-free survival versus anastrozole. In patients with long progression-free survival, as a surrogate endpoint of endocrine sensitivity, the sequential of endocrine agent can be considered. Also, combination of 2 endocrine treatment as first-line in postmenopausal has been included recently in the NCCN guidelines, although the 3 trials that address the combination of endocrine treatment, the fact the SWOG SO226 and the SOPHIA trials, only the SWOG showed that there is an improvement in overall survival in patients who received combination chemotherapy. And finally, we can find an overview of the clinical pathway for treatment. Is it a suggested pathway by the ESMO and the NCCN guidelines? Here we can start with endocrine treatment with CDK4/6 inhibitor as first line. If the patient progressed and there was no prior use of CDK4/6, we can use it in the second line. If there is prior CDK4/6, either to add apelizumab or to add everolimus, or if there is visceral crisis, we can add chemotherapy. Also, PARP inhibitor in case of BRCA1 mutation 1 or 2, or pembrolizumab or larotrectinib or entrectinib can be used. If no CDK4/6 inhibitor have been used before, it can be used at later at subsequent lines. If there is no prior CDK4/6 inhibitor, we can use it or add it in any step of the disease. Thank you.
Thanks, Professor Amira, for your elegant presentation. Is there any question for Dr. Amira? Can I ask you a question, Dr. Amira? Just to take from your experience, your lecture is clear and depend on guidelines. On which base will you select the first line CDK4/6 inhibitor for advanced breast cancer patient? Is it according to the comorbidities of the patient, site of metastasis?
According to the comorbidity in the patient, CDK4/6 inhibitor as first line to be added to the endocrine treatment is the best preferred option unless there is visceral crisis that necessitates chemotherapy. If there is no visceral crisis, then we can start it with endocrine treatment. We choose between the 3 drugs according to the comorbidity. Cardiac patient, we know that ribociclib is associated with prolonged QT interval. Also, the young lady who will receive tamoxifen with complete ovarian suppression, this may add to the effect of ribociclib, and hence ribociclib is not preferred in this group of patients. Older patients who have bone marrow is not adequate due to old age, we know that ribociclib and palbociclib will cause and increase the bone marrow suppression, and hence the abemaciclib is preferred. I think we can switch between the CDK4/6 inhibitor according to the toxicity, unless there is other contraindication.
Thank you, Dr. Amir. Thank you. It's my pleasure to introduce the second speaker, Professor Ayman Abdessamia. He will talk today about risk-tailored adjuvant therapy in early HER2 positive breast cancer.
Thanks, Mr. Chairman. مساء الخير عليكم كلكم. أرجو أن تكونوا يعني لسه فيكم طاقة تسمعوا المحاضرة. My lecture today is a practical one. No odd names, no scientific, a lot of scientific backgrounds. My talk is about risk-tailored adjuvant systemic therapy in HER2-positive early breast cancer, and my talk was restricted to adjuvant early breast cancer, not neoadjuvant, not metastatic. As we know, this is my disclosure. My agenda is introduction, standard therapy, de-escalation strategies, algorithm for treatment, and take-home message. As all we know, HER2-positive breast cancer constitutes about 20% of the metastatic disease and about 12 to 15% of the early breast cancer. HER2-positive breast cancer is not one disease, it is multiple disease, as we saw in this figure. There is HER2 hormone receptor negative, HER2 positive hormone receptor negative, and the HER2 positive either ER positive or BR positive. As we know, HER2 disease is a poor prognosis without chemotherapy, as shown in this graph. It is the least of the 3 types of breast cancer subtype, but with Herceptin it improved even. This is the line above is the HER2 positive become the most favorable one. So The standard one-year adjuvant HER2-based therapy came from the famous 4 pivotal trials, the HERA and the NCBB B31, NCCTG N9831, and the B-Search. From all these trials, adjuvant trastuzumab lead to decrease in decrease the rate of death by about 30% or 40%, decrease the death by about 25 to 30%. So, one-year adjuvant trastuzumab combination with 3 to 6 months of chemotherapy remains the current standard care for adjuvant systemic therapy. But it reduces the risk of recurrence up to 40% in relative risk of death by 30%. The benefit of trastuzumab was across all subgroups, independent of the patient tumor size, lymph nodes, hormone receptors. Long-term follow-up showed that approximately, in spite of this adjuvant trastuzumab, about 25 to 30% of patients will recur. That is to say, there is a room to improve over this. It is not enough to give this. This is the rationale for escalation. By contrast, there is also emerging evidence that subset of patients can de-escalate treatment without compromising the outcome, with added benefit of reduced toxicity and the treatment cost, what is called low-risk recurrence, and this will be discussed in de-escalation strategies. Let us start by escalation or intensification, what is called adjuvant therapy in high-risk HER2-positive breast cancer, and it is in the red definition of high risk. It is lymph node positive, certainly. Tumor size more than 3 centimeters, and others. So, building upon adjuvant 1 year of trastuzumab, we have 3 strategies. Either extended treatment in neratinib extend trial, or adding dual HER2 in affinity trial, or TDM1 in residual disease after neoadjuvant treatment of HER2-positive breast cancer. The affinity trial is a large trial comprising about 5,000 patients, stratify high-risk breast cancer into chemotherapy plus trastuzumab, pertuzumab, or chemotherapy plus trastuzumab placebo. After follow-up about 10 years, the trials met its primary endpoints, which is invasive disease-free survival, and secondary endpoints, which is overall survival. As shown in this curve, at 6-year follow-up, the disease-free survival of the combination group, I mean Pertu with Trasto, was 90.6 versus 87.8. This is the whole population intention to treat analysis. Subgroup analysis shows that this effect is increase in node-positive breast cancer. It reached about the delta, the difference in even free survival, about 4.5%, but in node negative, it nil. The two curve became the same. And the hormone receptor status does not affect the result of the study. This is an interim analysis of the overall survival, and as you see, there is no overall survival benefits of the comparator arm with the standard arm, either by lymph node negativity or lymph node or hormone receptor. So the conclusion of affinity study, clinical benefits continue to be observed with addition of pertuzumab to adjuvant chemotherapy and Trasto in patients with HER2-positive breast cancer, regardless of the hormone receptors. But absolute benefit in invasive disease-free survival at 6 years in intention treatment to treat analysis was 2.8%. Clinical benefit was profound, as we saw in node-positive patients with absolute benefit in the invasive disease-free survival at 6 years, 4.5%. No significant benefit reported in current interim analysis. Primary cardiac event incidence remain more than 1% in both arms. That is to say, affinity trial is a good positive trial in high-risk patients. And as you see, there is no overall survival benefit, only restricted to high-risk HER2-positive breast cancer. So even in Canada and Australia, they didn't embrace for pertuzumab in the adjuvant setting. Not in Egypt, in Canada and in Australia. Extent trial. This trial, the largest trial, about 3,000 patients, randomized HER2-positive breast cancer, ended their therapy. And 1 year after or 2 years after, they started neratinib versus placebo. And after inclusion of some patients, there is amendments that they remove the patients who received more than 1 year of end of trastuzumab. The primary endpoint was invasive-free survival, and secondary endpoint was overall survival. And as you see, the trial met its primary endpoint with difference about 3.5% between the maintenance neratinib and the other. It's very important note here is the difference is more significant in hormone receptor positive patients, which is not hormone negative. In hormone receptor positive, the difference become more evident. The other strategy, which is the post-chemotherapy treatment, this is the Catherine trial, which is an international randomized open-label phase 3 trial. Randomized patient HER2-positive breast cancer, locally advanced at first, receiving anti-HER2, either PER2 plus Trasto or Trasto before the inclusion of PER2 in the neoadjuvant. And after surgery, if there is residual disease, they classify the patient into either to continue the standard, which is the anti-HER2 for 18 cycle or TDM1 for 14 cycle. The trial met its primary endpoint in the disease-free survival, and the difference was TDM1, the 3-year survival of TDM1 is 88.3 versus 70.7%. The absolute difference is a big one, about 10%, but please take care. There is an abstract was published in the Journal of Clinical Oncology just in June 2020. They do a meta-analysis, 3 years survival in randomized trial of chemotherapy and HER2 target therapy meta-analysis. They found that the event survival or disease survival rate is not so low like Catherine trial. And the cause of this that in the recent year we use pertuzumab as an adjuvant and neoadjuvant, and we use pertuzumab as neoadjuvant. So the number of patients who developed or have residual disease is less than shown in Catherine trial. So the escalation approach, I have two options, the escalation of anti-HER2 or de-escalation of chemotherapy. The escalation of anti-HER2, as you know, was addressed. The question is this shorter duration of Trasto, non-inferior to 1 year. This was addressed in many trials. Most of them are negative, the short hair, the SOLT, the FAIR, and the HORG, and the positive one with the New England trial, Persephone, which is the largest one. Persephone is a randomized trial certifying about 1,000 patients in each arm between short duration, 6 months of HER2 and 1 year of Herceptin. The trial it is non-inferiority trial. And it's very important to know what is the non-inferiority trial. Non-inferiority trial, the investigator should have a consensus on the level which they accept to be accepted for them to show is any difference between the two arms. The trials met its primary endpoint, and it doesn't cross the that the trial met its primary endpoint, that there is no inferiority between 6 months to 12 months. And this was evident along all the subgroup of patients. Only the patients with hormone receptor negative saw marginal benefit of the 12 months. The patient with anthracyclines who received anthracyclines adjuvant, marginal improvement in the 12 months. The patient who received concurrent Taxol with or concurrent chemo with Herceptin shows marginal improvement. Otherwise, all the subgroup are the same. Overall survival, as you see, there is no difference between the overall survival between 12 months and 6 months. And this is the subgroup analysis in the overall survival. It is the same as the disease survival. CAR toxicity, absolutely less than 12 months. 8% in the 12 months developed cardiac toxicity, 4% in 6 months. Cardiac function recover post-trastuzumab rapidly. For 6 months, in 12 months it recover slowly. So meta-analysis of all the 6 trials, including Persphone, short hair, solid trials, the meta-analysis showed that traditional meta-analysis have favored 12 months of adjuvant trastuzumab compared to shorter duration. However, a trend toward decreased benefit of 12 months was noted in lower risk patients. This population may include patients with low disease burden, for example, tumor size less than 2 centimeters, 0 to 3 lymph nodes. A recent meta-analysis, which was published just 1 year ago, of these 5 non-inferiority trials, and showed this found while invasive survival with 9 weeks of trastuzumab was not non-inferior to 12 months, but 6 months is not non-inferior to 12 months. Indeed, completing more than 12 months of adjuvant Herceptin increased marginal improvement in the overall survival in the invasive survival 7%. Despite this commonly used clinical practice, we should encourage the use of 6 months Herceptin in certain patient population. The escalation of chemotherapy, rapidly, I have only 5 minutes, is the original adjuvant HERA trial. They used anthracycline-based chemotherapy. This was questioned in the research trial when they removed the anthracycline by the TCH arm, Taxol with Herceptin and carboplatin, and the overall, the disease survival almost the same. Also the overall survival, and there is no sub-patient who does not benefit from the non-anthracycline regimen, either node negative or node positive. And this numerical advantage, there is only numerical advantage in the ACTH over TCH, but this advantage on the cost of 21 case of chronic heart failure, which represent 5% more increase in the cardiac failure, and about 8% of the group receiving AC developed acute leukemia. Another type of de-escalation of chemotherapy is the ABT trial, which choose patients with low-risk group, tumor size less than centimeter, lymph node negative, and they give only weekly Taxol 12 weeks with Herceptin. And as you said, it is the same as the classic one, and this is opens the room for de-escalation of chemotherapy in low-risk patients. Another one is the ATTEMPT study, which is chemotherapy-free adjuvant treatment when women with HER2-positive breast cancer stratified between post-surgery TDM1 alone or paclitaxel plus trasto. and although the trial not met its end primary point, that the Trasto plus chemotherapy is better than TDM1, but due to the low toxicity and the higher quality of life of TDM1 patient, we can recommend TDM1 as a monotherapy in elderly patients of low risk. The other trial, which is a RESPECT trial in elderly patient, also randomized patient between trastuzumab monotherapy or Trasto plus chemotherapy, and the result, although it does not meet its primary endpoint, but it is possible or logic to give this monotherapy in elderly patient. So this is a proposed algorithm, and I take it from the Canadian study group. We are talking about this with the contour in clinical stage 2-1A, 2-1A or T1B. We go for upfront resection. Not all HER2 positive should receive neoadjuvant. HER2 positive breast cancer T1A, T1B may go or should go for upfront surgery. Then, according to the results, we gave the adjuvant chemotherapy. If tumor less than 3 centimeter, N0, N-mic, we de-escalate the chemotherapy, as you said. If the tumor is more than 3 centimeter with or without lymph node positive, we gave the standard adjuvant chemotherapy. And the adjuvant chemotherapy, as we said in the other trial. If there is a residual, we can go for extended neratinib treatment. So conclusion and take-home message, the advance in HER2 target therapy has led to important shifts in the paradigm of treatment of HER2 positive breast cancer, but not one size fits for all. يعني the old policy to use only all the adjuvant one year adjuvant trastuzumab with chemotherapy and cyclin-containing should be challenged. Recent data demonstrates that many of the patients and the chemotherapy backbone duration and nature can be modified or targeted according to the individual risk, as we shown in the previous slides. Patients with stage 1 disease can often manage with upfront surgery and evidence-based de-escalation adjuvant chemotherapy regimen. The modest benefit of 12 versus 6 months of HER2 therapy or dual adjuvant HER2 therapy should be carefully weighted against the toxicity, financial and physical toxicity. All patients with HER2 positive breast cancer should be enrolled in ongoing risk-tailored treatment trial. And thank you, and sorry for
Thank you, Dr. Ayman, for your excellent presentation. The floor open for 1 or 2 questions.
بعد إذن حضرتك يا دكتور أيمن, if we are going to talk about يعني mass treatment, cannot in all times treated altering patient by patient. So especially لو في recommendation جاي من higher authority, فلو أنت هتنصح الهاير authority ده والgrouping, which patient would you advise in adjuvant treatment? The group, not the patient, the group of patients that it is might be not inferior to receive 6 months of trastuzumab as an adjuvant, and for which patients would you omit pertuzumab as a part of adjuvant treatment? Group of patients. شكرا.
شكرا Dr. Hussain for this important question. And you means authority in our country, not recommendation from outside, because I know there is some schools or مبادرة presidential بيستخدموا international guidelines. So if I will give him advice, let us start stage by stage. In the neoadjuvant setting, only dual HER2 blockage, PER2 plus Trasto, should be given in high-risk patients. That is, say, clinically lymph node positive or tumor size more than 3 centimeters. If it is not this, trastuzumab is enough, as we show. Trastuzumab is enough as a neoadjuvant. If we go for adjuvant, in the classic or the low-risk patient, we can give trastuzumab alone, as I saw to you, not pertuzumab. If it is high-risk patient, we should give pertu with trasto. Okay? In low-risk patient, elderly patient, hormone receptor positive patients, you can give trastuzumab monotherapy plus endocrine therapy. This is my recommendation, and I think in the panel, which will help by Dr. Amani, we can reach a consensus for this.
Okay, thank you, Dr. Ayman, for your presentation. The next speaker, our colleague, Dr. Muhammad Awad, Professor of Medical Oncology from Mansoura University. His talk about HER2-low and old entity with new hope.
Thanks, Dr. Hanan, for your nice introduction. Dear professors and colleagues, it is my distinct pleasure and great honor to be here with you today. Allow me first to thank Professor Dr. Amani and the organizing committee for giving me this opportunity. So I have been given an easy task today, HER2-low and old entity with new hope. This is my agenda for over the upcoming 15 minutes. First, an overview of HER2-low breast cancer, the definition and the challenges. Traditionally, HER2-low breast cancer has been defined as a score of 1+ by immunohistochemistry or 2+ with negative each. However, this definition has a lot of challenges. The first one comes from the HER2-0 is not actually 0. And a significant number of patients show some sort of staining. The second challenge is here. Actually, after 20 years of experience, still HER2 is very difficult to measure. The ASCO CAP themselves, the guidelines have changed several times. And in a recent report, among 18 experienced pathologists, there was only 26% concordance regarding discrimination between IHC 0 and +1. Another challenge comes from the intratumoral heterogeneity. In fact, there is a higher prevalence in synchronous mets compared to the primary. We have also temporal heterogeneity. HER2-low is not stable over time. And the rate of HER2-low increases with each subsequent biopsy. The incidence of HER2-low correlates well with ER expression. In triple-negative breast cancer, it is only 40% as opposed to 60% in luminal E tumors. Now we'll come to the bust. Is it black and white? Actually, HER2 expression is a continuum. It is a continuous variable. It is not a dichotomy. However, the guidelines have divided it into positive and negative to allow the selection of therapy based on the efficacy of trastuzumab only in positive cases. In HER2-low, the addition of pertuzumab failed to add any benefit to trastuzumab. TDM1 also has low activity, if any. However, there was an unexpected finding. In reanalysis of pivotal trials of trastuzumab, 10% of samples were actually non-amplified. And unexpectedly, they derive the same benefit from adjuvant trastuzumab. So a recently published trial was conducted, which is a phase 3 randomized trial of adjuvant trastuzumab in HER2-low breast cancer. Can you spot any difference in the survival curve? In fact, exactly the same. So, can we declare the end of the continuum? No HER2-low, and we go back to the dichotomy? Don't believe in this, I will tell you the truth. This is me almost 5 years ago. At that time, I received a very important phone call. Actually, Prof. Dr. Amani phone called me and asked me to prepare a topic about highlights of the best of ESMO that we have attended at that time. And I selected this topic. It is a trastuzumab vaccine in HER2-low breast cancer. The drug is called Nelly-Bibimut-S. My problem with this trial is the difficult name to pronounce. What is Nelly? Nelly is an immunogenic peptide. When attached to HER2 protein, it invites trafficking of immune T cells, something like what we call it bispecific antibody used in hematologic malignancies. The trial was tested in HER2-low. Actually, there was a 6% benefit in the disease-free survival. However, it didn't reach statistical significance. But in triple-negative cases, it was significant. So we have a new hope. However, the present is not the tale of the vaccine. It is the tale of the evolution of ADC or antibody-drug conjugates. This is the classic antibody-drug conjugate, the TDM1 or the Kadcyla. It is an antibody directed against HER2-positive breast cancer cells. The antibody is conjugated to a payload, which is a very potent chemotherapy. The payload is usually very potent, more than traditional chemotherapy. For example, in hematologic malignancy, we use vedotin, which is almost 3,000 to 5,000 more potent than vincristine. We have here also the TDM1, which is much more potent than the taxanes. It is conjugated to the monoclonal antibody. However, there is the linker, and the linker is tightly binding the antibody to the drug to prevent release of the drug into the systemic circulation. When the antibody binds to its receptors, there is internalization of the antibody drug conjugate inside the cell. And then with time, it takes a very long time for endosome recycling and endosome digestion of the monoclonal antibody, and then release of the active drug inside the cell. It will take action and kill the cell after some time. And after killing the cell, the drug will be released into the surrounding tissues, causing what we call it bystander effect. It will kill some of the cells that do not express HER2. With innovation, we have a more recent antibody drug conjugate, which is trastuzumab deruxtecan. The linker here is cleavable linker. It can be cleaved only inside the tumor tissue by malignant tumor enzymes. So the drug is really removed. It doesn't wait so long time until digestion of the antibody. We have also a different payload. We have deruxtecan, which is 1,000 times more potent than irinotecan. It has very high potency. Also high drug-to-antibody ratio due to binding to the cysteine residue, 8:1. The drug is membrane permeable, so the payload is released from the cell readily into the surrounding tissues, causing mass destruction of neighboring cells not expressing the HER2 target, what's called very strong bystander killing effect. This drug has been tried in phase 1 study, and as we see in the waterfall plot, magnificent objective response rate, and as we see below in the spider plot, the response rate was maintained. This unprecedented, robust, and durable efficacy in phase 1 trial led to the direct jump to the phase 3 study. It is the destiny 4 in breast cancer of TDXD versus physician choice chemotherapy in HER2-low breast cancer. Patients who are AR positive should have received at least endocrine therapy and should be considered endocrine refractory. 90% of those patients were hormone receptor positive, and 10% were hormone receptor negative. The investigator choice chemotherapy was very active: eribulin, capecitabine, paclitaxel, nab-paclitaxel, or gemcitabine. The patients were well balanced regarding the baseline characteristics, and almost 70% of HR positive patients received prior CDK4/6 inhibitor. The trial was essentially positive with a hazard ratio of 0.5. This means 50% reduction in the risk of progression, which translates to 5 months improvement in the PFS. There is also reduction in the risk of death by almost 40%, which translates to more than 6 months improvement in the overall survival. The drug was active across all subgroups with impressive objective response rate of almost 53%. The drug was well tolerated except some GI toxicity. We know that we have used chemotherapeutic agents including eribulin, paclitaxel, capecitabine, and all these drugs are already low emetogenic. So the main toxicity with this drug was nausea and vomiting. It's okay, we are comparing this drug not to anthracycline, we are comparing to low emetogenic chemotherapy, and the drug produced much less neutropenia. However, with new technology, we should be careful that we will have new toxicity. We have warning for interstitial pneumonitis or interstitial lung disease that is usually mild, but it could be fatal, so we have to be aware and warn our patients. We should also monitor for left ventricular dysfunction. Another potent monoclonal antibody or monoclonal drug conjugate is the sacituzumab govitecan, and this drug has something unique. It has a pH-sensitive linker. This pH-sensitive linker will readily release the tumor by acidic microenvironment inside the tumor tissue. So non-expressing cells will also be subject to the bystander effect. In fact, the TROP2 is expressed in many tumors, including breast cancer, but the majority of expressions occur in metastatic triple-negative breast cancer. The B-load here is the active metabolite of irinotecan. It is 2,000 times more potent than irinotecan. We cannot use it in clinical practice, otherwise the patient will die. But with antibody-drug conjugate, the antibody will deliver the active drug only at the tumor area. The first study is the ASCENT trial, which was tried in triple-negative breast cancer patients. We have a hazard ratio of 0.4. What is nice about this study is that it was halted early based on efficacy per an anonymous decision, like the knockout we see in boxing. We have also improvement in the overall survival. The drug was safe with no interstitial pneumonitis. Another drug, which is the TROPICS-2, sacituzumab govitecan, was tried in hormone receptor positive patients, but in a heavily pretreated populations. And the drug was also active in this subgroup. Importantly, this drug was active in the, we know that hormone receptor positive, almost 60% of them will be HER2 low, and the drug was active in the HER2 low space also. So what about the future? Now, the trastuzumab deruxtecan is being compared on what we call it ultra low, which is between 0 and 1. And we have to await the result of the Destiny 6 trial. We have also more and more novel antibody drug conjugates. The technology has arrived. It will stay and it will progress. We have also combinations with various chemotherapy, endocrine therapy, and immunotherapy. So the classic dichotomy has been shifted to hormone HER2 positive, HER2 low, and HER2 negative, and the HER2 negative space is now being challenged into HER2 ultra low. Thank you.
Thank you, Professor Mohammed, for this elegant presentation. Do you have any questions for the doctor? Yes, Dr. Ayman.
Thank you, Professor Mohammed, for this elegant, concise presentation. I have one question and one comment, if you allow me. A question about the trastuzumab vaccine. I don't remember its name, as you said, it's a difficult name. What is more effective in HER2 low patients and in triple negative, I think so? Triple negative?
It is effective in HER2 low. 40% of triple negative will be already HER2 low, yes.
In HER2 positive, is it effective or not tested?
It is tested in HER2 low only.
Only?
Only, yes.
They didn't test it in HER2?
They tested the vaccine only in HER2 low.
low.
Yes, in HER2 low space.
This is nice.
Yes.
My comment in 1 minute about the drug trastuzumab deruxtecan. I think it is a magic drug.
Yes.
And it is a magic drug in oncology, not in breast cancer, in stomach cancer, and other cancers. And I think it will be one like tamoxifen as endocrine treatment in breast cancer, and trastuzumab as an adjuvant. And all the time now moving trastuzumab deruxtecan as first line, it already second line metastatic HER2 positive based on, as you know, destiny.
It is the innovation of the technology, Dr. Ayman. يمكن الانوتوزوماب مثلا في ال في الريلابسد ريفراكتوري 70% سي ار. الاتسترس في الهوتشكن في سواء كان في البوست ترانسبلانت مينتنس هو التكنولوجي. يعني التكنولوجي في انتي بودي دراج كونجوجيت هاز ارايفد هيبروجريس. يعني within few years هتلاقي a lot يعني بليثرا اوف دراجز.
من وجهة نظري انا راجل بريستاوي قديم او بريست انكولوجيست، فشايف ان التراسوماب دروكستيكان ده هيبقى هو
طبعا
الحصان الرابح يعني. شكرا.
I have a question, Dr. Awad. Do you think that indications of treatment in low HER2 breast cancer will depend just in HER2 status, or we should classify those category of patients into again risky and low, high risk and low risk?
No, we should classify based on the HER2 status after referring to the AR status also. Because in HER2 low we can use trastuzumab deruxtecan or sacituzumab govitecan only after failure of endocrine therapy.
Thank you. Thank you, Dr.
شكرا.
It's my pleasure to introduce our next speaker, Professor Sami Esrafi, who will talk today about the early integration of palliative care into the care of advanced cancer patients.
بسم الله شكرا دكتور ايناس. بسم الله. اولا بشكر دكتوره اماني استاذتي مش زميلتي طبعا على الدعوه الكريمه دي، وان هم ده يعني they were keen to integrate palliative care in the multidisciplinary program of the conference. My topic is why the integration of palliative care is needed. انا كنت عاوز احضرها انها how to integrate palliative care، لكن لقيت لسه ما زال هنا في مصر احنا محتاجين نفهم الناس ليه palliative care needs to be integrated. يعني palliative medicine is recognized as a medical specialty in UK now for 35 years. وبعد بقى لي كام سنه في مصر 14 سنه بشتغل palliative. يعني just few days ago someone يعني in a position يعني مش هكلم كلينيشن او حاجه he said no palliative care is a luxury. ازاي palliative care is a luxury؟ ده بالعكس، ده هنشوف دلوقتي لازم we have to integrate palliative care. I have nothing to disclose. What's palliative care؟ طبعا حضراتكم حضرتوا المحاضرات في المؤتمر و all through the sessions شايفين الانوفيشنز والادفانسمنتس والنيو تريتمنتس، but the reality is that millions of cancer patients, breast and other cancers, die every year. Millions die every year. Okay, and the only realistic treatment plan and only management plan for them is palliative care and cancer pain control. So palliative care is an approach that improves the quality of life. It aims at improving the quality of life of patients, their families facing the problem associated with life-threatening illnesses, through the prevention, relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. What's the impact of palliative care? First, طبعا لو شفنا الديفينيشن بتاعه الايم بتاع palliative care الاساسي is quality of life. Do you have any evidence that palliative care improves really the quality of life of patients with life-threatening illnesses with advanced cancer? طبعا this is a review published 2010, 12 years ago, and most of the references in these presentations are old references, and I did not update these references. Okay? أنا عاوز أوصل المسج إن الكلام ده موجود for years, for decades. The evidence is there, but we are very much lacking behind the world. Not only high-income countries, even low-income countries, as you will see. This is a review done by Irene Higginson from King's College in London. What's the evidence that palliative care teams improve outcome of cancer patients and their families? أنا مش هقرا طبعا ريفيو ومش هقرا الكلام فيه، أنا بس هوريكم الليست of trials or studies اللي قالت إن palliative care is effective. Okay, this is just a demonstration. Was it effective in improving the quality of life? This is the very famous, probably this is the most famous palliative care article in the history of palliative care by Jennifer Timmel and her colleagues from Mass General Hospital in Boston, published in the New England Journal of Medicine in 2010 and cited thousands of times today. This was about the early integration of palliative care. What's the impact of early integration of palliative care on patients with advanced lung cancer? It was a randomized control trial. This is the study design. They randomized 151 patients to early palliative care integrated with standard oncology care. And in this group, the patients will meet the palliative care team within 3 weeks after enrollment. Newly diagnosed lung cancer patients, good performance status ECOG 1 and 2. From the beginning, they will receive oncology care, and at the same time, they will continue with the palliative care team. At the same time, this is the intervention group. The standard oncology care group meet the palliative care team when requested by the patient. Okay, the patient will start with the oncology team, and if it happens that the patient requested to go to the palliative care or the oncologist decided to consult palliative care, it's okay. But palliative care will not start from the beginning. And this is the intervention. I will not talk about the details. These are the guidelines for the palliative care delivery in the States. This is the outcome. These are the scores of the quality of life. This is the FACT-L, quality of life questionnaire for lung cancer patients. This is the lung cancer scale. The standard care, the score was 92, and the early palliative care was 94. This at baseline. There was no significant difference between both. And lung cancer subscale and tried outcome, none of them were significant. After 12 weeks of oncology care and palliative care in the intervention arm, this is the FACT-L score, the total FACT-L score. In the standard care, it was 91. In the early palliative care, it was 98. And the difference was statistically significant with the median effect size. The same for the lung cancer subscale and for the trial outcome index score. It was highly significant with the median effect size. So palliative care is proved to have an impact on quality of life. But let's have a rapid look on the team of the Mass General Hospital palliative care team at that time. We can see that they have how many physicians? About 8 physicians, 5 nurse practitioners. They have 7 fellows, international clinical research 2, administration, and so on. So they have a true palliative, multidisciplinary palliative care team, large one. So, and this is the outcome of such palliative care team. The impact of palliative care on survival. Okay, people may think that when we send patients to palliative care, this means that the survival will be shortened, especially if you are giving opioids, you are giving tranquilizers, you are giving benzodiazepines, and so on. In the same trial, okay, although it was not the primary outcome or the primary endpoint of this trial, what they have found, these are the survival curves for the 2 arms. This is the survival for the early palliative care, and this is the survival for the standard care. For the standard care, it was 8.9 months, the median survival, and it was 11.6 months for the early palliative care. And this is a huge difference for patients with advanced, with incurable metastatic lung cancer patients to 2.7 months survival advantage. This is a big advantage for early palliative care, and it was statistically significant. And this is another retrospective studies. It shows that patients who are referred to hospice, they have a significantly, highly significant overall survival when compared to patients who are not referred to hospice in the United States. Aggressiveness of end-of-life care. What is the impact of palliative care on the aggressiveness of end-of-life care? And what's aggressive end-of-life care? There are some, now there are quality indicators to assess the quality of end-of-life care, and these are examples. If the patient is going frequently to the emergency room near the end of life, this is aggressive end-of-life care. If the patient is receiving chemotherapy during the last 2 weeks of life, this is aggressive. If the patient is admitted to the ICU near the end of life, this is aggressive. If the patient died in acute setting, acute care hospital, this is aggressive setting, and so on. Let's see what's the impact of palliative care on this aggressive care. And this is just an example. The role and time of palliative care medicine consultation for women with gynecological malignancies, association with end-of-life interventions, direct hospital costs. We can see that the red bars, they did not receive palliative care, and the blue bars, they received palliative care. And for all, the difference was significant. More than one ER visit was significantly higher. This is the only one. ICU admission was significantly higher for patients who didn't receive palliative care. More than one hospital admission near the end of life was significantly higher with no palliative care. And the same was for more than 14 days hospitalizations or death in acute care setting. So palliative care, early palliative care integration, and in this particular study, they defined early integration is palliative care integration before the last 30 days of life, okay, not near the end of life. So it decreases the aggressive end-of-life care. What's the impact of palliative care on the place of death? Why it is important? Because we are talking about patient-centered care. If the patient is wishing to die at home, and we can help the patient and his family, the patient to die at home, so we are achieving a huge goal. This goal, we are respecting the patient wish and his family wish. We are reducing the costs, okay, and we are removing resources to other places. The studies we did in Qasr Al-Aini, published 3 years ago, about the preferred place of death for patients with incurable cancer and their family caregivers. We asked the patients and their family caregivers, where do you prefer the patient to die? The majority of diets, it included more than 300 diets, patient and caregiver diets. Home was the preferred place of death in 93% of patients and in 90% of family caregivers, and there is no significant difference between them. So the majority of patients and their family caregivers, they prefer death at home. Did palliative care help patients die at home? This is a cluster randomized trial published in The Lancet in 2000, 12 years ago. A palliative care intervention and death at home, a cluster randomized trial, palliative medicine unit intervention program that aims to enable patients to spend more time at home and die if they prefer to. It was a randomized control trial. We'll jump to the findings. Almost 400 patients died. Of these, more intervention patients than controls died at home. 25% versus 15%, less than, and the difference was statistically significant for patients who received palliative care. They were more significantly to die at home. So palliative care is effective in helping patients dying in their preferred place. What about opioid consumption? Why you are talking about opioid consumption? Because actually it is an indirect indicator for the control of pain. It is recognized by the WHO as an indicator. WHO monitors morphine, opioid consumption in individual countries as an index of improvements in pain management. This was a study done in Spain by Carlos Centeno and his colleagues and published 2009 BMC Palliative Care. They reported the opioid consumption before and after the establishment of a palliative care unit, and this is what they have found. Implementation of palliative care unit in a university hospital is associated with a higher and more adequate use of opioids. This indicates better pain control. And we did a similar study at Qasr Al-Aini, opioid consumption before and after establishment of our unit in 2008. The opioid consumption significantly rose almost sevenfold from before in 2006 to 2011, almost sevenfold increase in the opioid consumption, meaning that there is better pain control. What about the cost of care? And this is a concern of many administrators. Okay, am I going to pay money to help people to die or not? This is cost effective or not cost effective? There are a lot of studies, and as I said, I chose all the studies. We have evidence now for many years. This study published in the reputable journal Archives of Internal Medicine in 2008. The cost savings associated with U.S. hospital palliative care consultation programs, the study was done in 8 hospitals in the state, and included 2,600 palliative care patients who were discharged alive and matched 18,000 usual care patients. So they compared palliative care patients who were discharged alive and a comparable group of patients. And they compared more than 2,000 palliative care patients who died in hospital with a matched 2,000 usual care patients, and to see the difference in the cost. And this is that we have found. This is for the live discharge. For patients who were discharged alive from the hospital, those who received palliative care had a significantly less cost. Total cost of the admission, significant. Total cost per day, direct cost per admission, direct cost per day, laboratory costs, ICU costs. This is logic. If you are implementing good palliative care and you are not doing aggressive end-of-life care, you are not doing unnecessary investigations, you are not giving unnecessary treatments, you are not doing unnecessary ICU admissions, for sure you will have less cost, and palliative care will save money for others. This is for the live discharge, and this is for the hospital deficit. They found the same. The total cost per admission decreased significantly. The total cost per day, direct cost per admission, in all domains, it had a significant effect. That the cost was less, significant in favor of palliative care, except the imaging cost. But overall, palliative care was associated with less cost. Okay, so we have now an intervention that improves the quality of life. Okay, that help the patient and their families do what they wish, they die at home, that better symptom control, less cost, okay, less aggressive end-of-life care. So in total, palliative care should be integrated into the care, and the care of cancer patients in Egypt. And thank you. Shukran.
Okay, thank you, Dr. Sami, for your comprehensive presentations. And floor open for one or two questions to Dr. Sami. Dr. Mohammed, تفضل.
شكرا دكتور سامي، يعني فيري اكسلنت برزنتيشن. هو الحقيقه مش سؤال، هو انا كان عايز اقول حاجه. انا في بدايات الاميونوثيرابي كنت بحضر توبيك على كان الاميونوثيرابي بيتعاطى في السكند لاين في اللان كانسر، فكنت بشوف هو جايب سرفايفل قد ايه، فكنت عملت سيرش كده على كل الترايلز اللي جابت سرفايفل في السكند لاين في اللان كانسر.
تمام.
فالنيفولوماب كان بيتعاطى في الفتره دي، كان مع بدايات النيفو، كان جايب اوفرول سرفايفل 3 شهور. انا فاكر الرقم في السكويماس من 6 خلاها 9، وفي النون سكويماس من 9 خلاها 12، 3 مانثs. لقيت الايرلي بالياتيف كير جايب 6 مانثs
تقريبا.
يعني لو جينا نتكلم في الكوست، يعني لا مفيش اتصال فعلا. فهو فعلا فيري امبورتنت توبيك.
فيري امبورتنت. ما بقول لك اللي خلاني اقول برزنتيشن ان ذيس واي، الكومنت اللي انا سمعته، بالياتيف كير لاكشري دي حاجه، دي رفاهيه احنا مش ما نقدرش عليها في مصر، بالعكس العكس تماما. فده ميس اندرستاندينج اند اجنورنس للاسف الشديد جدا. يعني فمتشكر جدا لحضرتك على الكومنت يا فندم.
ليا برضه اكسبلينيشن دكتور سامي بيه. انا واحده من الناس اللي بتعتقد ان البالياتيف كير مع الكانسر بيشنت والنيوتريشنال سبورت دي حاجه بتفرق معانا في النتائج في الادفانسد كيسز. يعني أكيد. هو استفسار، هل ممكن البالياتيف كير كان بي بروفايدد ات هوم؟ يعني هل ده بيحتاج مني مثلا تريننج للكير جيفرز، الفاميلي كير جيفرز مثلا، مع متابعه مننا، او ممكن الامور تمشي ازاي؟
طبعا سؤال مهم جدا حضرتك دكتور ايناس، وشكرا لحضرتك. طبعا هو كل الفوكس دلوقتي والدبليو اتش ريكومنديشن والانترناشونال ريكومنديشنز كله بيتكلم على الكوميونتي بالياتيف كير. بالياتيف كير ات هوم، ذيس از ذا جولد ستاندرد بالياتيف كير. هنعمل ايه ومين اللي هيروح وهنعمل ايه للعيان في البيت والكير جيفرز هيبقى، ده بيختلف من مكان للاخر على حسب الكالتشر، بيختلف على حسب الريسورسز، بيختلف على حسب الاندرستاندينج اند سو اون. يعني في اماكن بيعملوا فعلا هوسبيس ات هوم، يعني ممكن بيبقى عنده اراوند ذا كلوك نيرسينج كير. ده ممكن ما يكونش متاح عندنا. ممكن احنا هنا في مصر بالذات، انا رايي ان احنا نعتمد على فاميلي كير جيفرز اكتر. يعني في يو كي في ستاديز طلعت تقريبا نص الناس اللي بيداي اباف 75 دي داي الون ات هوم. فدول محتاجين يكونوا في هوسبيس. لكن هنا في مصر لما عملنا كومباريزون لقينا اكثر من 90% من البيشنتس اللي بيداي الداينج كانسر بيشنت دي هاف فاميلي كير جيفرز ات هوم. والفاميلي كير جيفرز في مصر هنا، يعني مش عاوز اقول لك يعني خبرتي معاهم محترفين. يعني في ناس بيتعلموا يدوا حقن وبيدوا بيغيروا وبيعملوا، يعني ممكن يساعدونا كتير جدا. فايه يعني انسب صوره لان يبقى الكوميونتي بالياتيف كير او هوم بالياتيف كير احنا اللي نحدده. لما نبتدي احنا اللي نحدده. تمام ان شاء الله. اتفضل.
اول ما حضرتك كنا بنجيب سيره البالياتيف كير، وبالعكس هو زمان الناس ما كانتش اكسبتنج قوي، وانا بحيي حضرتك انك لسه لغايه دلوقتي متمسك بالموضوع ده، يا رب على طول. بس دلوقتي بقى في زي منظمات اهليه او حاجه بتبقى زي مش برايفت، هي بتبقى بتقدم الخدمه مجاني. احنا حتى بنتعامل معاهم في بالي، احنا ما عنديش مكان ان انا اعمل ايزوليتد بالياتيف كير او الكلام ده بقى موجود دلوقتي، ما كانش موجود مثلا من 10 سنين. تفتكر ده حضرتك بيساعد؟ يعني هل ممكن نساعد الناس انهم يعملوا الحاجات دي اكتر، لان هم مثلا بداوا يبقى عندهم ويتنج ليست، يعني ما يقدروش يروحوا لكل الناس في نفس الوقت؟ لو توسعنا في القصه دي هل ممكن تساعد مثلا؟
طبعا حضرتك، يعني اللي موجود في مصر دلوقتي يعني ممكن
2 أو
يفيد less than 0.1% من النيدز، لكن اللي موجود انا عارفهم، يعني عارفهم بيشتغلوا ازاي وبيشتغلوا فين. قليل جدا قليل جدا، يعني بالعكس احنا محتاجين كتير جدا جدا جدا. تمام. يعني ممكن يعني الناس اللي عاوزين يبتدوا ياخدوا دول كرول موديلز ويبتدوا يعملوا زيهم. طبعا كان نفسنا في القصر هنا، بس احنا وي ار فيري بيزي طبعا مع البيشنتس. عندنا مثلا 3000 اكتر من تقريبا 1000 عيان في السنه، فاتس فيري بيزي سيرفيس يعني معانا يعني. لكن اتمنى يعني ذيس از ماي دريم بروجكت صراحه، يعني ان يبقى في هوم كير سيرفيس، هوم باليتيف كير سيرفيس، يعني ذيس ماي دريم بروجكت ان شاء الله. اتفضل. شكرا.
Thank you, Dr. Sami. The next, it's my pleasure to introduce my dear colleague, Dr. Sarah Shamsuddin, lecturer of clinical oncology at Qasr Aini Hospital, also medical oncology consultant at Bahia Cancer Center. Here to talk about management of breast cancer in elderly patient. Go ahead, Dr.
Thank you, my professor, for this chance, and thank you for all the wonderful lectures coding the systemic and the active therapy or the palliative therapy, and I'm trying to integrate both in this subgroup of patients, the elderly patients. We are going to go through the mammographic screening benefit should be balanced with the cost, and what is going to be its role in the elderly. Frailty is an essential part of the comprehensive geriatric assessment, and then the breast conservative surgery and the breast reconstruction options in the elderly. The auxiliary surgery in the older patient can it be omitted or substituted. Age by itself doesn't represent an absolute exclusion criteria for chemo. Endocrinal therapy remain the most widely used for adjuvant treatment for breast cancer in older, and the radiotherapy after breast conserving surgery can it be omitted, or it's either an option for the compliance. Elderly definition, there's two definitions, chronological age, and we will later gonna know the biological age. Chronological age of at least 65 years define elderly or older person in most developed country. But this definition may not be easily applicable to many developing country with the low socioeconomic status and the comorbidities. As epidemiology of the breast cancer in the elderly, over 40% of the breast cancer is diagnosed in women older than 65 years of age in developed countries, as shown in this figure. Since 1990, breast cancer death rate has been steadily decreasing by 2.5 per year in women aged less than 75 years, but only by 1.1% year in women aged more than 75 years. And this, like shown here, and we will talk later why the incidence was increasing, but due to screening program, but the mortality is decreasing due to the early detection. There's a relation between the cancer and the aging. Increased risk of the cancer in the aging population may be attributed mainly to damage of the DNA result as a cumulative exposure to carcinogenic chemicals, radiation, and viruses. Also, the decline of the host defense against tumor growth. Here, there's the aging process with all the host immunity affections or as releasing of the interleukin, and the less for defense from the carcinogenesis, and also the frailty of the impaired functions and low socioeconomic and comorbidity. Pose those factors together in cancer patients who have to receive therapy without suboptimal outcome. With the background and the changes of pharmacokinetics, the volume of the chemotherapy in the elderly, the volume of the chemotherapeutic drug distribution will be affected in anemia, changes in the total body water, serum protein level, and also the changes in the pharmacokinetic will be affected by the clearance of the chemotherapeutic drug will be affecting glomerular filtration rate, the blood supply for the hepatic blood flow, and the cytochromes enzymes. Elderly people are more likely to express multi-drug resistance. This changes in the pharmacodynamics carry poorer prognosis, like in the poorer prognosis for the acute leukemia happening in the elderly. In addition, the tumoricidal effect of the chemotherapy or radiation usually need a well-oxygenated cells, which is not in the pool circulations for the elderly. Now after this background, I'm gonna start with the first point, the screening. The major determinant of the development and the survival for the breast cancer appear to be the breast cancer screening and the adjuvant therapy. In Europe, mortality due to breast cancer decreased between 1994 and 2024 by 13%. The decrease in the women aged group 35 to 64 years, 17%, compared with only 6% for the women aged 65 years. Retrospective cohort study for the effect of the mammographic detection and the comorbidity on the survival of older women with the breast cancer was 5,186 patients with breast cancer aged 65 and older. Mammogram screening of the breast cancer, reduction in the risk of the death for the patient with mild to moderate comorbidity. However, this wasn't evident with improvement in survival with severe and multiple comorbidity. The mammographic screening upper age limit has been extended to 75 years of age in most of European countries and the USA. ASCO recommended mammography in older patients who have a life expectancy of 10 years or more, and life expectancy is calculated according to the population and who have a statistics analysis for the population. Assessment of frailty is an important part and should be integrated in the treatment of the elderly patient. It's a multidisciplinary assessment. It takes 45 minutes to perform regarding physical, nutritional, psychological functioning of the elderly, help to more accurately determine the biological age of the patient, not only the chronological age. Those are the factors that is usually assisted in the comprehensive geriatric assessment with the different tools for assessment from the MDTs. A meta-analysis found several statistically significant benefits for the patient who had a comprehensive geriatric assessment performed, including a significant reduction in deaths or deterioration for all patients admitted to the hospital, not only for the cancer patient. And especially regarding the cancer patients, there are a few guidelines for the NCCN guideline. We will will recommend the same assessment for the elderly before decision making. The management decision in the elderly with the patient few guideline for the management of the elderly in the patient with breast cancer due to lack of representation of the elderly in the randomized controlled trial. Here the proportion of the cancer patient and the elderly represented in the clinical trials. The biological characteristic for the elderly usually a higher ER and the PR over an 80%, a lower KI and a low HER2, low P53. Going to the treatments, this treatment will offer a primary surgery. There's a randomized trial, surgery plus tamoxifen versus tamoxifen. Should we go for surgery or only for tamoxifen alone? And women aged over 70 years with operable breast cancer. And their randomization was surgery plus TAM or TAM only, with an improvement in the progression-free survival rate. But still, the TAM could maintain a 3 years same survival as a surgery, especially in the patient with lower life expectancy. So we can offer both surgery or TAM for after adequate evaluation for the patient. A meta-analysis concluded primary hormonal treatment with TAM is inferior to surgery, whether without hormonal, in terms of local control, progression-free survival, and medically fit older women, defined by the geriatric comprehensive assessment and other assessment tool, and don't result in significantly better overall survival. Despite the idea that elderly weren't well for breast conservation, but actually a big portion of the patient willing for breast conservation, should we offer it? Surgical treatment of the breast cancer among the elderly in the USA. 81% in this elderly age group, which was 5 aged group tells the more than 85, was offered breast conservative surgery as indicated, the primary management among the elderly. On the other hand, we should, the compliance with the adjuvant radiation treatment should be taken into account when designing a tailored treatment plan for this group. In case of the cases that found to have a lower use of the breast conservative surgery was the advanced age over 85, a comorbidity, and the low socioeconomic status. Axilla, the details about the surgery due to the time for operations going to some shortening the time. So sentinel lymph node biopsy for the elderly patient with the tumor of less than 2 to 3 centimeters. No clinical evidence of axillary involvement is the standard of care. But also there wasn't data about an axillary lymph node involvement in the patient was up to 70 is less presented with axilla. The curve still go up again due to reasons host immunity. Axillary dissection versus no axillary dissection in older T1 and 0 breast cancer patient, 15-year results for these trials, randomized trials. And this age group from 65 to 80, clinically N0 radiographic diameter 2 centimeters. The patient randomized quadrantectomy with or without axilla, or received radiotherapy to residual breast not to the axilla, and was prescribed tamoxifen. The 15 years follow-up distance metastasis overall survival and breast mortality for axillary dissection. No axillary dissection was the same. Should we offer reconstruction? The reconstruction in the elderly have some limitation, like breast implant poorly tolerated. Cosmetic outcome are quite different than the physiological breast. Autologous flap, a surgical procedure might be more demanding. Adjuvant chemotherapy among a node-positive postmenopausal aged patient, anthracycline have been shown to improve overall survival, and anthracycline containing dentaxane has significantly improved the 5-year disease-free survival. The CALGB retrospectively reviewed 4 randomized clinical trial of the treatment for the lymph node positive breast cancer recruited till to 1999. 6,487 patients, only 8% were 65 years and 2% was 70 years older or older. And intensive chemo showing the all age group showing better progression-free survival and overall survival. Similar reduction in the breast cancer mortality and recurrence for younger and the older who received chemotherapy irrespective of the hormonal receptors. The CRASH is a tool that can predict the risk of a severe toxicity in the older patient with cancer starting a new chemotherapy. And this is score points, so we can put on the scale to expect the toxicity that's going to have in the high-risk patient. Managing of the chemotoxicity guideline from an ERTC and the ASCO specify recommended prophylactic colony-stimulating factor only for the patient who is expected to have febrile neutropenia 20% or higher. In our case, evidence-based use of a colony-stimulating factor for elderly cancer patient systemic review in age by itself is a risk for febrile neutropenia, 48% versus 8% for the patient, and the use of the growth factor appeared to be the best established strategy to improve treatment in older patients. Geriatric assessment-driven intervention on a chemotherapy-related toxicity effect in the older adult with cancer and randomized trial and other trials that stress on the importance of implications of these tools for assessment before taking decision in the elderly population. Targeted therapy, 6 large randomized trials, as mentioned in the HER2-positive disease lecture, were designed to test the role of trastuzumab as adjuvant therapy after surgical treatment, despite the different in the patient population are designed. All have showed a significant improvement in the disease-free survival among the women receiving trastuzumab. So the SAG guidelines for elderly, in the absence of a cardiac contraindication, adjuvant trastuzumab should be offered to older patients with HER2-positive breast cancer when chemotherapy is indicated, but cardiac monitoring is essential. Hormonal therapy, the patient with invasive breast cancer that are ER or PR positive should have adjuvant endocrine therapy regardless of age, lymph node, whether adjuvant chemotherapy is to be administered. In the early breast cancer trials, collaborated overview analysis of the data. In a patient with ER positive breast cancer, adjuvant tamoxifen decreased the annual odds of recurrence by 39% and the annual odds of the death by 31%, irrespective of the use of the chemo or the patient age or menopausal status or axillary clearance. Lymph with increased risk for was it tamoxifen, ischemic cerebrovascular event, endometrium cancer, hot flashes, venous thromboembolic event, and vaginal bleeding. And we are here talking about a subgroup with of elderly, with some of them already having this as a comorbidity, so that should be considered. Results of the ATTAC trial after completion of 5 years of adjuvant treatment for the breast cancer ATTAC trialist. The subgroup analysis of the ATTAC of the woman aged more than 65 years had a greater benefit from anastrozole than from tamoxifen, but was the risk of carried was as anastrozole was higher risk of bone fracture, musculoskeletal pains, a higher rate of osteoporosis among women treated with AI who had osteopenia at the baseline. And so, with this different two profile of toxicity for the two major key players of adjuvant treatment, hormonal therapy, letrozole and tamoxifen, and BAG198 trial, tamoxifen followed by letrozole have the same efficacy with the different toxicity profile for the both, and so the patient could be shifted during their adjuvant treatment. APT early breast cancer trials collaborative group meta-analysis for treatment with prophylactic zoledronic acid to protect against bone fracture and maintain bone health. Neoadjuvant endocrine therapy for the elderly is a very important treatment, because sometimes we need this active treatment who can with manageable toxicity while improving the frailty patient or the comorbidity, but not leaving the patient without treatment at all for a while. Radiotherapy, postoperative radiotherapy for after breast conservative therapy is essential for decreasing recurrence and the mortality. The trial lumpectomy plus tamoxifen with or without irradiation, aiming to omit irradiation post conservative surgery in the elderly patient. And this trial recruited 636 patients over 70 who has stage 1 T1N0 ER positive receptors, and they were randomly to tamoxifen plus radiation or tamoxifen only. And there's better locoregional control, but that wasn't translated into better survival, which means we can, for this stage 1 elderly, we can omit radiation after conservative therapy. The same indication in the younger women cell needed for chest wall and lymphatic for the advanced stage. Hypofractionated regimen improve compliance for those group of patients. Supportive care, there is a medication commonly used for supportive care and should be taken with concern in older patients, like corticosteroid. Some of them for pain, some of them for antiemetics as resulted from chemotherapy, corticosteroid, benzodiazepine, first generation antihistaminic, antiemetics, and all this list. Considering initiating all medication at the lowest possible dose and the increased dose gradually as tailored. Conclusion, as by 20% of the population is anticipated to be aged over 65. We are far from fully understanding the biology and optimizing the treatment of this rapidly expanding age group. More evidence by prospective randomized trial is needed to help decision making in this special population. Thank you.
Thank you, Dr. Sarah, for your presentation. Is there any questions? Yes, Dr. Ayman.
جدا على المحاضره التجميعه، يعني جميله جدا. انا ليه بس كومنت، هو الانثراسايكلينز كادجفنت هو اثبت ان هو مور سوبيريور عن بقيه الكيموثيرابي، بس في الالدرلي وي شود تيك ان كوشن. اولا هو انديكيتد ولا مش انديكيتد، والعيان كومبلكس بتاعته ايه، ولو فرق مش هيفرق كتير قوي. بس this is my comment.
وكان ليه كومنت برضه دكتوره ساره الستاتستكس بالنسبه للايدج جروب في البريست كانسر، يعني لو نحط في ايجيبت، يعني اللحظه كله كان في امريكا وفي اليوروب، بس نحط حجم الايدج كده حطيتيها في اخر سلايد. شكرا جزيلا، محاضرة كانت شاملة، شكرا جزيلا. Finally, our last speaker, Professor Sharif Hassanin, he will talk about oligometastatic breast cancer, the endless dilemma.
Good evening to everyone, and thanks Dr. Amani for inviting me for this event. Really a tough subject. Oligometastatic breast cancer, the endless dilemma. I have no disclosures, and this is my agenda. The oligometastatic state was first described by Hillman and his group based on the spectrum theory of cancer spread. They postulated that metastatic disease occurs on a spectrum, including a clinically distinct intermediate stage between locally confined disease and widespread distant metastasis. In this intermediate stage, the disease may have a more indolent biology. The concept of oligometastasis represents a condition midway between locally confined cancer and a disseminated disease in which tumor burden is low and the number of affected organs is limited. The term oligometastasis means few from the Greek word oligos. However, an exact number of lesions is rarely defined. Oligometastatic disease in general, including breast cancer and other malignancies, have been defined in some studies as the presence of 1 up to 5 distant metastases in less than 2 organs. Although most studies have limited inclusion to patients with 5 or fewer metastases, however, some have included patients with up to 8 metastatic sites. The term de novo oligometastasis or synchronous oligometastasis describe limited metastatic disease at the time of the initial cancer diagnosis and includes both an untreated primary tumor in addition to limited metastasis, while oligorecurrence describes patients who develop limited metastasis after initial definitive treatment. Why the number of 5 was selected? This is a relatively old study, about 40 years ago, discussing a multivariate analysis of prognostic factors in metastatic breast cancer. The study showed that survival was significantly higher in patients with less than 5 metastatic lesions, and since then it was considered that any patient with 5 or less metastatic sites may be treated or defined as an oligometastatic breast cancer case. Theoretically, can these patients be cured? Given the likelihood of limited spread, it's possible to achieve longer survival, and even in 2 to 3% of cases, we may have cure with aggressive metastasis-directed therapy. Given this, it was hypothesized that treatment of all non-cancer post-primary tumor and metastasis could lead to long disease-free intervals and potentially even cure. What about the workup we should consider or do when you are facing a case of oligometastatic breast cancer? The basic imaging is mandatory. Our CTs, of course, consider PET-CT, and very important is to consider MRI brain. Because brain metastasis in the newcomers breast cancer is relatively low, 0.4%, but data revealed that this number may rise about 20 times to reach 8% in patients with extracranial metastasis. So if you have a patient with liver or lung or bone metastasis and even she doesn't have any cranial symptoms, you may do MRI brain because there is a significant possibility that she will have brain metastasis. We have the OligoCare study, which is an ERTC pragmatic observational basket study. This study is collecting patients from all types of malignancies, not breast only. It's aiming to evaluate the radical radiotherapy for oligometastatic cancer patients. They recommend in the ERTC research and the treatment cancer imaging group to do PET-CT, consider PET-CT in cases of oligometastatic breast cancer patients, and also they recommend to do a specific MRI with liver-specific contrast agents if you is suspecting liver metastasis, especially if less than 1 centimeter, because in this situation the PET scan may be less sensitive than MRI in case of small liver metastasis. Whole body MRI is more or less similar to PET regarding sensitivity and specificity, but it is less available, and the PET MRI may be the upcoming future. What about treatments of the primary or the primary tumor in metastatic breast cancer cases? We have retrospective series of thousands of patients consistently showed an overall survival advantage with a pooled hazard ratio of 0.65 to 0.7 from radical treatments of the primary tumor, either by surgery or definitive radiotherapy, but we have unresolved questions regarding the local treatment details from these retrospective series, which includes what time upfront surgery or after systemic treatment, the extent of surgery, the need for radiotherapy after surgery, the need for free margins. All these questions were unresolved. Can metastatic breast cancer patients get a real benefit from treatments of the primary? There is a meta-analysis which included 10 studies in this context. It included more than 28,000 patients from 10 studies. More than half of them did surgery to the primary tumor, 52%, and it showed a superior 3-year survival for resected patients with a good odds ratio of 2.3. The subgroup analysis from this meta-analysis favored smaller tumors, less competing medical comorbidities, and importantly, lower disease burden as significant factors associated with better survival. The type and the extent of the local original treatment which was done in these retrospective studies, data for the type of surgery were available in more than 14,000 patients. Most of them did mastectomy, 39% only did breast conservation. One of the studies comparing the two procedures found no difference. Regarding the axilla, most of the patients in these retrospective studies underwent axillary resection, only 7% had sentinel node biopsy. 2 studies from the 10 studies found no overall survival improvements in patients undergoing dissection of the axilla, while another one showed reduced the risk of death with the dissection in patients with negative margin, but it was not significant. Margins were positive in 43%, but 2 studies demonstrated that patients with negative margins had the longest survival. What are the drawbacks of this analysis? The data presented are limited to retrospective studies, and the results are confounded by the fact that surgical patients had a more favorable profile before operative intervention. These studies mostly included selected patients with better performance status and less advanced primary tumor. Also, most of these studies, the data on the HER2 positive patients are missing, limiting the applicability of these results in all disease subgroups, and especially in our modern era of very effective anti-HER2 target therapies. So it is difficult to correlate the outcomes from local treatments in relation to the disease biology in these reports. I would like to highlight these numbers. This was the median survival reached in most of the studies. You may notice that the data or the numbers are relatively very low in comparison to our recent systemic therapies. The median survival in most of the studies ranged from 2 to 3 years, which is far below our systemic treatments or our achievements done by the very recent biological and systemic treatments nowadays. What about prospective data? Do we have prospective data regarding surgery? We have 5 randomized controlled trials in 5 different countries. The results of the trials overall showed no significant difference in survival between patients undergoing surgery versus those receiving systemic therapy. In the Turkish trial, there was a trend towards improved survival in patients with bone-only disease, limited metastatic burden, and favorable histology. So generally, no improvements in overall survival from doing surgery added to systemic therapy, but in a subgroup analysis from Turkish trial, patients less than 55 years and those who had solitary bone metastasis may have longer survival from addition of surgery to the primary tumor. What about metastasis-directed treatment? We have many data on using SRS, stereotactic radiosurgery, as a treatment of metastasis in oligometastatic breast cancer patients. Overall, the 10 studies included more than 500 patients. All the studies except 1 study were single arm, 6 studies were retrospective. Analysis from 7 studies, which included patients who had between 1 and 5 metastases, reported very good local control rates at 1 and 2 years, between 86.9 and 100% at 1 year, and between 79 and 100% at 2 years. Regarding the progression-free survival, the 1-year PFS ranged from 38 to 80%, and the 2-year PFS ranged from 8 to 75%. So, the above-mentioned studies consistently showed that local ablative radiotherapy in oligometastatic breast cancer patients leads to very high local control rates in the range of 90%. And it may lead to a more or less favorable PFS or overall survival according to the disease and the patient-specific criteria. And this was the base for the quantitative meta-analysis, which included these 10 studies, and it was published 1 year ago, and included more than 400 patients. The 1 and 2-year local control rates were excellent, 97% and 90% respectively. The overall survival at 1 year was 93%, at 2 years was 81%. Toxicity was minimal. Only a prospective design of the included study and bone-only metastases were significantly associated with better overall survival. So the conclusion of this meta-analysis for SRS, that stereotactic ablative body radiotherapy for oligometastatic breast cancer is safe and associated with high rates of local control. However, longer follow-up of the existing data and ongoing prospective trials will help further to define the role of this management strategy. Do we have prospective data on the metastasis-directed treatment? This is a recent phase 2 trial for standard of care systemic therapy with or without stereotactic body radiotherapy and or surgical resection for newly diagnosed oligometastatic breast cancer patients. The study included oligometastatic breast cancer patients with only 4 or less extracranial metastases. Patients with brain metastases were excluded. They must have controlled primary disease. They were on the first-line standard of care systemic therapy for less than 1 year without progression. They were randomized to receive either standard of care systemic therapy with any palliative local control if needed, versus standard of care systemic therapy plus metastasis-directed therapy with either SRS or surgery or both. And the primary endpoint was progression-free survival, and it was a negative study. The median PFS in arm 1 was 23 months versus 19.5 months in the arm 2 with an insignificant p-value. The same applies to the 24 and 36 months PFS, arm 1 and arm 2, no significant difference. The same applies to overall survival. So this prospective phase 2 randomized trial was negative, and the author decided not to go for phase 3. How to individualize and which factors you should look and consider when you are treating your patient as an oligometastatic breast cancer. The number of metastases is very important. In general, the available data showed that prognosis regarding survival endpoints decline with increasing number of metastases. Wycombe et al. Identified a solitary metastasis as an independent prognostic factor for PFS and distant control with very good hazard ratio. So 1 metastasis versus more than 1 is sure different. Another author, Steenberger et al., based on a Netherlands cancer registry study, evaluated 612 breast cancer patients with oligometastatic disease and showed that patients with maximum of 3 metastases versus more than 3 metastases had an estimated 10-year overall survival of 14.9 versus only 3.4. The hazard ratios for overall survival in patients with 1 metastasis was very good, 0.7. In the group with 2 or 3 metastases, it was 0.63, while the group of patients who had 4 or 5 metastases didn't differ from those who have more than 5 metastases. Another important factor you should look to the timing of the metastasis, oligorecurrence versus oligometastasis. Dawood et al. Analyzed a large cohort of metastatic breast cancer patients. The results suggest that patients with synchronous metastasis or de novo have a significantly better overall survival than those with metacoronous metastasis. Interestingly, on the other hand, if the metastasis occurred more than 5 years after the initial diagnosis, the difference in survival was not significantly different compared to patients with synchronous metastasis. Another author revealed indeed better overall survival rates for patients developing metastasis more than 5 years after diagnosis with a significant p-value. The breast cancer subtype may be surprising. The HER2 positive breast cancer subtype had the best data and the best rates regarding overall survival when we use stereotactic body radiotherapy to treat the metastasis, and many studies confirmed this, while the worst or the least data are for the triple negative breast cancer. So HER2 positive breast cancer patients when treated with SBRT may have the highest numbers and the highest survival rates. Also, the bone-only metastasis is a very important factor, and many studies revealed that patients with bone-only metastasis have far better survival rates. Milano Hotel study revealed that the 5 and 10-year overall survival after SBRT for a patient with bone-only metastasis compared to patients with metastatic lesions at other sites were 83 and 75% versus 31 and 17. Also, the local control at 10 years for treatments with SBRT for bone metastasis was 100%. Another study by David Hotel reported a very excellent 2-year local control of 100% for SBRT in bone metastasis. All the studies confirmed that, and the study done by Whitjanja Hotel included patients with oligometastatic breast cancer treated with SBRT. They revealed that the presence of visceral or brain metastasis was associated with an inferior prognosis compared to bone-only disease with very significant hazard ratios, which confirm that presence of visceral or brain metastasis is much worse than only bone metastasis. So which patients you may consider to treat aggressively and you may have curative intent? Patient with less than 3 metastatic sites, patient with oligometastasis rather than oligorecurrence, patients without brain metastasis, HER2 positive patients rather than triple negative, patient with excellent response to systemic treatments, and a patient with only bone metastasis, and a patient with their primary tumor amenable to local treatment. My take-home message is that most of the data point to the actual presence of the oligometastatic breast cancer diagnosis, and metastatic breast cancer patient with less than 5 metastatic sites are mostly considered as oligometastatic. Although retrospective data showed that patients with metastatic breast cancer can get benefits regarding overall survival from the treatment of their primary tumor, especially those with low disease burden. However, prospective trials failed to show the same benefits. MDT and especially SRS can achieve very high local control rates. However, the recent phase 2 randomized trial failed to show any significant benefits in PFS or overall survival from the addition of MDT to standard of care systemic treatments. Favorable groups of oligometastatic breast cancer patients, example those with bone-only metastasis and less than 3 metastatic sites, may be candidate indeed to aggressive treatments and definitive treatments to all known cancer sites, and this approach may even lead to cure. We have no solid data to determine the exact optimal local treatment which can be used in these patients, either surgery alone, surgery plus radiotherapy, necessity of achieving negative margin, axillary lymph node dissection. All of these are open questions with no definite answer. Very important, my opinion or my recommendation that we should remember that patient with only one measurable lesion or even single bone lesion were included in all the recent trials which use systemic therapies, and that these patients did got benefit from the use of recent biologic agents. So I recommend that systemic treatment is still the standard of care of all metastatic breast cancer patients, giving the very high overall survival rates which were achieved in the recent years by CDK4/6 inhibitors and the anti-HER2 antibodies. And we should remember that the overall survival rates achieved recently are much more high than the rates achieved by addition of local treatment of the primary tumor to a standard of care systemic treatments. And thank you.
Thank you, Dr. Sherif, for your excellent presentation. The floor, question for Dr. Sherif.
ممكن سؤال لدكتور شريف. هي آخر سلايد فيها حاجتين مش عارفة، حاسة إن هو مش عكس بعض يعني. على أرض الواقع لو حضرتك عندك حالة بريست كانسر وعندها سولاتري متاسس في دورزال فيرتيبري واحدة، هل حضرتك هتعمل تعالجها كأنها ايرلي ولا حضرتك هتكتفي بسيستمك تريتمنت؟
والله انا رايي ان الموضوع يبقى يعني زي ما كده حل وسط. لو هنتكلم على ايفيدنس بروسبكتيف راندومايز ترايل زي ما قلنا في اخر سلايد، البيشنتس دول كانوا انكلودد، يعني كل الترايلز بتاعت السي دي كي 4/6 انهبيتورز او الانتي هيرتو نيو او اي افكتيف سيستميك ثيرابي كان بيسمح بوجود وان ليشن، وكان بيدي السيستميك ثيرابي تيل بروجريشن. انا رايي ان ده الستاندرد اوف كير، بس مع مراعاه ان احنا ممكن العيانه دي نعملها مور اجريسيفلي. مفيش مشكله احنا لو عملنا لها سيرجري للبرايمري تيومر او اخذت اس بي ار تي للدورسال ميتاستس، لان دي الحاجات دي افكتيف من الداتا السابقه. لكن اللي انا يعني حاسس ان هو ممكن ما يكونش اكيوريت قوي ان احنا لو حرمناها من فكره الفيري افكتيف سيستميك تريتمنتس بناء على ان هي ممكن تكون تعامل كانها ايرلي، فحرمناها مثلا من السي دي كي 46 او الانتي هيرتو نيو انتي بوديز مثلا، فهنبقى اي ثينك ان ده مش هيبقى ايفيدنس بيزد قوي. فانا شايف ان القصه ممكن تكون يعني ان بتوين. she should receive systemic therapy meanwhile she may get benefits من ال definitive treatment سواء البرايمري او الميتاستاسيس.
احنا نتبادل الخبرات عن مكاننا. احنا ممكن بنختلف شويه، يعني ممكن الحاله لو من المواصفات دي احنا بنعالجها كانها ايرلي، بمعنى انها لو محتاج انيوجن بتاخد، لو هي فور جراحه بتعمل جراحه، والسنجل سوليتر ميتاستاتيك سايت احنا بنديله راديكال راديو ثيرابي دوز زيه زي البرايمري. ما شاء الله كانت النتائج كويسه. وفي حتى بالمناسبه كان عندنا رساله من فتره يا زميلتي دلوقتي استاذ مساعد كنت انا مشرفه عليها، كان اكسجن للبرايمري تيومر في حالات الميتاستاتيك، بس دي كانت ريتروسبكتيف ستادي، يعني كان ما بنقعد في الام دي تي في الجراحه تيجي الحاله ده راحت للجراح الاول عمل لها فبتطلع انها ميتاستاتيك، فوجدنا مع المتابعه والفولو اب ان لما بعمل اكسجن البرايمري لا يعني النتائج بتبقى احسن. بس طبعا لو هي limited number of الميتاستيز، لو هي بون اونلي ميتاستاتيك، كل دي بتخلي النتائج عندي احسن. يعني
ما هو الداتا اللي احنا عرضناها بتقول كده ان البرايمري يعني البيشنتس اللي بيعملوا ريسكشن البرايمري بيستفيدوا، بالذات اللي عندهم لو ديزيز بيردن، فالحته دي احنا متفقين عليها. لكن هي الجزئيه اللي انا يعني مش عايز اظلم العيانين قوي الحقيقه بالامانه، ان البيشنتس اللي حتى عندهم سنجل ليجن دخلوا في الترايلز بتاعت السي دي كي 46 والانتي هيرتو نيو، وفي ميتا اناليسيز على السي دي كي 46 انهبيتورز، بس يمكن انا ما عرضتوش لان هيبقى طويل، يعني ان كل البيشنتس بيستفيدوا سواء اللي عندهم بون اونلي سواء اللي عندهم.
احنا ممكن نقسم الكلام في الايرا قبل السي دي كي 46 والايرا بعديه، لان زي ما حضرتك بتقول السي دي كي 46 ما شاء الله جايب نتائج كويسه.
دلوقتي بنتكلم حتى على الايرلي، يعني احنا عندنا داتا على الابيما سايكل في الايرلي، فما بال حضرتك لو انا عندها بالفعل مثلا سنجل بوني ليجن اي ثينك انها سبوز ما تتحرمش من فرصه الافكتيف سيستميك تريتمنتس. يعني
دكتور اسامه اتفضل.
هو مصداقا للقول حضرتك، هي الفكره ان احنا عندنا ترايلز في البرايمري تريتمنت في الميتاستاتيك بريست وفي الميتاستاتيك كولون ما كانتش قد كده، وفي نفس الوقت عندنا ترايل في الاوليجوميتس بعد ريكارنس بعد ما كنا عالجنا برايمري ما كانتش قد كده. فانا اعتقد الداتا لو جمعناها على بعض يبقى العيان اللي جاي له برايمري وعنده سوليتري ميتس او تو ميتس دول، يعني اي ثينك ما ينطبقش عليهم الداتا بتاعت اللي هي التريتمنت اوف برايمري ان ميتاستاتيك ديزيز اللي هي كانت فيها سام فيلير سواء في الكولون او في الريكتم سوري، طالما مش هعرف اعين الميتس او في البريست. لكن ان انا احط الداتا اللي طالعه من الترايلز، اعتقد ان اي كانوت اكسكلود او اقول ان العيانين زي ما حضرتك سيادتك بتقولي اللي هم عندهم سوليتري او تو ميتس ممكن ستيل without ان انا entering into clinical trial still accepted ان انا اعالج primary والميتس بستيريوتاكتيك راديوثيرابي، especially لو انا مدي نيو ادجفانت وجاب ريسبونس او biologically ان هم I know that they are subgroup of that might benefit. I think دول مش محتاجين even clinical trial. I see case by case ممكن ياخدوا. يعني شكرا.
هو بس يعني النقطه اللي انا يعني زي ما بقول يعني اخشى ما اخشاها زي بيقولوا ان يبقى ان ايثيكال ان احنا نحرم العيانين دول من السيستميك تريتمنتس، اللي هي ده وجهه نظري ان احنا البيشنت دول استفادوا، يعني دخلوا في الترايلز سواء الانتي هيرتو نيو او السي دي كي 46 واستفادوا، فاحنا ما فيش ما يمنع في رايي ان احنا ندي اللوكال تريتمنت سواء البرايمري او الميتاستاتيك، وبرده مين وايل ممكن نديهم السي دي كي 46 او الانتي هيرتو نيو، لان هم في سيميلار جروبس من البيشنتس دخلوا بالفعل في الترايلز كان عندهم 1 ليجن even single bony lesion دخلوا في الترايلز وكانوا يعني راندومايزد وكانوا انكلودد واستفادوا، وبالتالي ما يعني
دكتور حنان بس دقيقه هكمل. بس حضرتك قصدك ايه يا دكتور شريف ان هم نحرمهم من السيستميك ثيرابي؟
يعني هو في ناس لما بيجي لها بيشنت عنده سنجل بوني ليجن على سبيل المثال بيعملوا له برايمري سيرجري للبريست سي واس بي ار تي للبون وبيوقفوا تريتمنت على كده، بيتعاملوه كانه
ادجفانت تريتمنت على كده.
طيب ما هو ده اللي انا بقول ان هو مش صح في وجهه نظري، ان هو ما هو انت لو اعتبرت
حضرتك
العينه دي ايرلي.
ده برايمري برزنتيشن باوليجو ميتاستاتيك ببون مثلا، يعني عيانه جايه برايمري بريست كانسر وعندها اونلي بون. ما ده احنا برضو ان اور اوبينيون في معهد الاورام، واخد بالك حضرتك دكتوره اماني ممكن توافقني او تصححني، لو عيانه جايه باونلي بون ميت او اونلي ميت واحده بس and she can be amenable for either local treatment by surgery or radiotherapy, we treat her as an early breast cancer وبتاخد النيو ادجفنت بتاعها واخد دوت سيرجري وتكمل عادي. يعني انا
ما هو تكمل عادي دكتور ايمن مقصود بيها ايه؟ هل تكمل عادي بمعنى ان هي مثلا هتوقف عند 8 سايكلز كيموثيرابي مثلا؟
ما هو البروجنوز هيبقى احسن من السيستميك ثيرابي اللي هتاخده. يعني انت البروجنوزس وات ايفر ايرلي بريست كانسر از بيتر ذان ميتاستاتيك بريست كانسر وخدت سي دي 4 6 انهبيتور ولا خدت انتي هير 2.
هي بس المشكله في السيستميك تريتمنت بتاع العيانه الاوليجو ميتاستاتيك، هي ستيل عندها مايكرو ميتاستاسيس، فهي شود بي تريتد از ميتاستاتيك بالرغم ان انت بتعالجها از ايرلي. انا مش عارفه انت واصل لك يعني مثلا
وجهه نظري كده
الانتي
يعني
هيرتونيو لو العيانه عندها metastatic breast cancer when she's treated with systemic treatment with trastuzumab, she should continue trastuzumab until لما يحصل حاجه تانية بقى، مش for 1 year ونوقف، لان هي الهدف من الادجوفنت is the treatment of micrometastasis، والعيانه دي عندها micrometastasis خلاص مهما عملت هي عندها مش عندها مايكرو، ده هي عندها ماكرو ميتاستاسيس.
بس خلاص. انا طبعا انا خبرتي مش كتيره يعني، بس يعني الى حد ما لا الى حد ما احنا قدام شويه يعني.
اصل يعني دي ديبيتابل، هي ديبيتابل
لا many patients enjoy her life لما بنعملها بهذه الطريقه، يعني بنعملها انها ايرلي مش ميتاستاتيك. وبالنسبه للهير 2 انتي هير 2 في الميتاستاتيك برضه في ديبيت، هتكملي على طول ولا هتوقفي؟ يعني حتى العيانين اللي هم ميتاستاتيك اوفر ميتاستاتيك ما حدش في العالم بيكمل انتي هير 2 على طول.
لا ده يعني
عشان التوكسيسيتي،
لو حصل توكسيسيتي ده
عشان التوكسيسيتي يعني وعشان الكوست يعني بيوقفوا.
احنا عندنا عيانين يا دكتور ايمن مكملين على الانتي هيرتونيو بقى لهم 3 و4 سنين.
عندكم فين؟
دي ار دوينج فيري ويل في بهيه. اول ما بدانا دي ار ميتاستاتيك اند دي ار كونتينيو. عندنا احنا اول ما بدانا كان عندنا انتي هيرتونيو، العيانين القدام بتاعنا بيكملوا معانا، مش هرميهم يعني. لا بتوعي موجودين. ثانك يو فيري ماتش. المحاضره كانت فيري كلير. انا موافقه معاك جدا ان احنا لازم تاخد السيستميك تريتمنت الموست افكتيف، وعندي عيانين اخذوا سي دي 4 6 مع هرمونال and they went into CR and they continued، وكانت الدسكشن نعمل سيرجري ولا ما نعملش. المشكله يا دكتور شريف ان احنا ما عندناش سي دي 4 6. ما هو
ما فيش مانع،
هو مش معترض على السيرجري، بس الفكره انا ما عنديش فيرست لاين سي دي 4 6. يعني احنا دلوقتي في كلنا كيونيفرسيتيز ما عندناش فيرست لاين، فبيبقى ده احسن اوبشن للعيانه انها تاخد سيستميك وبعدين تعمل وتكمل هرمونال تريتمنت.
موافق مع حضرتك، بس بنفس المنطق يبقى هنكمل برضو الهرمونال في البروجريشن نفس الفكره يعني ايا كان الميثود اوف تريتمنت يعني. شكرا.
اوكي ثانك يو دكتور شريف for your presentation. Next speaker, it's my pleasure to introduce my beloved colleague, Dr. Mani Hilal, Professor of Medical Oncology, NCI, also is the Director of the Medical Oncology Department of Bahia Breast Cancer Center.
أنا عارفة إن إحنا متأخرين جدا، حاول وعارفة إن إحنا آخر اليوم، بس لسه إحنا عندنا MDT فعايزين نصحصح عشان عندنا MDT cases. My talk today الأول طبعا I want to thank Dr. Hanan for the nice introduction, my dear sister not friend. Thank you for AstraZeneca team for letting me share their data in Bahia for their contribution Bahia conference. My presentation is in promising advances in HER2 negative breast cancer treatment, closer look on the BRCA mutant disease. BRCA mutations associated with increased risk of cancer. This the information I think we all know. Look at the breast cancer, increasing the incidence of the developing breast cancer among the BRCA mutant patients from 12.9% in the general population up to 72% in patients with BRCA1 and BRCA2 disease. Not only breast, but also breast, ovarian, pancreatic, and prostate cancer. As long as the patient has a family history, this increases the incidence of or the prevalence of the BRCA mutation among the patients. And the However, not all breast cancer patients with BRCA mutant are identified using family history of breast and ovarian cancer, meaning that I shouldn't suspect BRCA mutation only in patients with family history of the breast and ovarian cancer. In one of the largest Swedish studies, 62% of breast cancer patients with BRCA mutation were reported to occur without a family history of ovarian or breast cancer, and we all can see this now. We have a lot of the young patients without a single family history within the patient, and I think many of them will be BRCA mutant. Higher proportion of patients with triple negative have BRCA mutation than those with hormone receptor positive disease, and we all know this information. But because of the higher instance of the hormone receptor positive disease constitute about 60%, 70% of all breast cancer cases. So numerically, the patients with hormone receptor positive have a larger number, but not larger percentage of the BRCA mutant disease. This is the NCCN guidelines for the whom should go for BRCA testing. Every year, if you are looking for the NCCN guidelines, you will find that they are broadening the indications for the BRCA mutant. Metastatic breast cancer is not a curable disease. The early breast cancer still have a lot of unmet needs. Every year we are looking for something to improve the outcome. So when we're finding something that can improve the outcome, then you should look for if there is any genetic mutation underlying. That's why the indications, personal history of breast cancer with the specific features, those younger than 50 years, and then come to the very broad indication. And I think it could delete all of the coming indications. Those for treatment indication, patient with systemic, to add in systemic treatment decisions using PARP inhibitors for breast cancer in the metastatic setting, and to aid in the adjuvant treatment decisions with olaparib for high-risk HER2 negative breast cancer. Meaning that if you have a patient with metastatic breast cancer or high-risk early breast cancer, they can go for BRCA mutation in a hope that they could be mutant, so we can add the adjuvant treatment or the PARP inhibitor. Other the indications, I think you all know, those with triple negative breast cancer, multiple primary breast cancers, lobular breast cancer with personal or family history of diffuse gastric cancer and mid breast cancer, and of course Ashkenazi Jewish families. Also patients with a lot of the relatives with breast cancer, mid breast cancer, ovarian cancer, pancreatic cancer, and high-grade prostate cancer, whether early or metastatic. BRCA mutation is an indicator of prognosis and disease course. The properties or the characters of the BRCA mutant disease, it tends to occur at younger age, tends to be of higher grade, and they associate with higher instance of CNS metastasis, and also higher instance of contralateral and ipsilateral disease, which makes common sense. The patients with the BRCA mutation, the average age at diagnosis between 35 and 44, slightly older with the BRCA2 mutation, 40 to 45, compared to 62 years median age at the USA and not in our country. Invasive lobular carcinoma, invasive duct carcinoma is the most common as in all cases, but invasive lobular carcinoma has a slightly higher instance in the BRCA2 mutant drug when compared to the BRCA1 mutant, BRCA2 mutant disease when compared to the BRCA1 mutant breast cancer. Okay. Patients with BRCA mutation has increased risk of ipsilateral and contralateral disease. A meta-analysis of 10 studies demonstrated significantly higher risk of ipsilateral breast cancer in patients with BRCA mutation, and several studies have shown contralateral breast cancer more often observed in BRCA mutant breast cancer than in sporadic cases. Now, patients with the BRCA mutant breast cancer may have a higher risk of recurrence than non-carriers. I have looked for the most of the studies in the literature, most of them saying that the BRCA mutant disease has a worse prognosis. Some couldn't reach this result. However, the meta-analysis showed the patients with the BRCA mutant breast cancer could have a worse disease. Patients with the BRCA mutant had a significantly higher risk of recurrence as measured by the Prosigna analysis, where the BRCA1 mutant versus BRCA wild type showed a hazard ratio of recurrence of 1.1, and the BRCA mutant versus BRCA wild for the BRCA2 also there is higher instance of the having a higher risk disease as measured by the multi-gene scoring. Also, patients with the BRCA mutant had significantly worse recurrence-free survival and distant metastasis. For the comparing BRCA2 mutant to BRCA1, BRCA2 mutant was associated with longer median time to relapse, but with the longer follow-up, the BRCA1 mutant, BRCA2 mutant was found to have the same median time to progression. The hope is the finding the treatment option for these patients with the BRCA mutant, which was the PARP inhibitor. We all know that function of the BRCA1 and BRCA2 is the repair of the double-strand breaks in the DNA, and the BRCA and the PARP also function is the repair of the single-strand, very rapidly single-strand break of the DNA. When we're using the PARP inhibitor, prevent the repair of the single-strand DNA due to accumulation of the double-strand breaks in the presence of, in absence of the BRCA1 and BRCA2 genes. There's accumulation of such double breaks resulting in the death of the cancer cell, which is not the case in the normal cell. Is there is room for the PARP inhibitor used in the early breast cancer? The function of the PARP inhibitors or the effectiveness of the PARP inhibitors have been proved, although modest benefit in the metastatic breast cancer with the improvement of the progression-free survival in patients with metastatic breast cancer. And as usual, moving from the metastatic trials into the early trials, we all agree that we have unmet needs in the patients with the early breast cancer. The majority of the breast cancers are HER2 negative and diagnosed at an early stage. Breast cancer accounts for the 12% of all new cancer cases, so the HER2 negative disease is the most common among all of the cancer subtypes. دكتور ماهر دخل لخبطني عشان أنا حسيت إن MDT بدأ. Sorry for that. Many early breast cancer patients experience recurrence despite of all of the improvement in the chemotherapy, giving dose dense, giving the anthracycline, adding taxane. Still, we have 30% of patients with high risk features experiencing recurrence with the few years after the treatment. And we all know the high risk factors: patients with the lymph node positive disease, those with the larger tumor size, patients with high tumor grade, and the patients who did not achieve the pathological complete response after the use of the new adjuvant chemotherapy. And this has been, these are the high-risk groups, just to be sure that these features associated with the high risk of the recurrence. All of these high-risk factors have been adapted in the Olympia trial. Inhibition or and trapping of the PARP inhibitor on DNA results. دي آخر سلايد ولا إيه؟ I'll go for the study design. Local genetic testing or one study central screening, the germline pathogenic BRCA1, BRCA2 mutation, HER2 negative, the hormone receptor positive or triple negative breast cancer, and the stage 2 and 3 breast cancer patients with the lack of response to the neoadjuvant chemotherapy. These are the patient population whether received the neoadjuvant chemotherapy or adjuvant. For the neoadjuvant, triple negative breast cancer not achieving the BCR, hormone receptor positive not achieving BCR, and having the clinical pathological stage estrogen receptor grade score more than equal 3. We will talk about this score in the next slides. And they received more than or equal 6 cycles of neoadjuvant chemotherapy followed by surgery and radiotherapy. As regarded the adjuvant group, included the triple negative breast cancer with whether a tumor size more than 2 centimeters or with positive lymph nodes. For the hormone receptor positive, it included the patients with more than or equal 4 positive lymph nodes. And again, patients went into upfront surgery followed by 6 cycles or more of adjuvant chemotherapy plus or minus radiotherapy. And then they were randomized in the 1-to-1 fashion to receive either olaparib, 300 milligram twice daily for 1 year, or the placebo. And these stratification factors were hormone receptor positive versus triple negative, neoadjuvant versus adjuvant, and the prior platinum-based chemotherapy, yes versus no. Of course, the patients received the concurrent endocrinal treatment if they required, the concurrent bisphosphonates if they indicated for, and no second adjuvant the chemotherapy. The primary endpoint was invasive disease-free survival, and the second endpoint was distant disease-free survival, overall survival, and the BRCA1/2 associated cancers, and of course safety. Certain clinical and pathological features define the patient as high risk with increased chance of distant metastasis. Just going into a very rapid revision for hormone receptor positive, those who didn't achieve pathological CR after neoadjuvant chemotherapy with the score of more than equal 3. For the triple negative, those who didn't achieve pathological CR on the neoadjuvant chemotherapy or the tumor size more than equal 2 centimeters and any positive lymph nodes. Now the score that has been adapted in the Olympia trial has been validated, created and validated by the MD Anderson Cancer Center. This software calculates the anticipated 5-year distant metastasis-free survival and disease-specific survival for patients with early breast cancer who received the neoadjuvant chemotherapy. The scoring system evaluating the prognosis in these patients by incorporating the pre-treatment clinical stage, the post-treatment, the pathological stage, as well as the estrogen receptor and the tumor grade. Using these 4 criteria, having the score, and this score again segregate the patients into those with low risk of recurrence or high risk of recurrence in the early breast cancer after neoadjuvant chemotherapy, so it's not for a metastatic disease. Score starts from 1 to 6, 1 to 2 considered to have a low recurrence risk, and in the Olympia trial included patients for more than 3 up to 6, score of 3 to 6 in hormone receptor positive patients and not in the triple negative. Patient characteristics, as you can see in the olaparib and placebo group, the patients are well balanced. For the distant number of patients with first invasive disease-free survival, in the placebo group, the distant recurrence occurred in about 22.6% and compared to 14% in the olaparib group. For the regional and ipsilateral recurrence, it's almost half by the addition of olaparib. For local, the ipsilateral recurrence, again, it's almost half by the addition of the PARP inhibitor. Contralateral invasive breast cancer is also reduced. As regarding the second primary non-breast malignancies, it's shown to be also reduced by the use of the PARP inhibitor. Death without a prior invasive disease-free survival, 2 in the olaparib group and none in the placebo group. And this is for the invasive disease-free survival. As you can see, there is an improvement in the disease-free survival at the 3.5 years. The invasive disease-free survival was 85.9% for olaparib versus 77.1%. And for distant disease-free survival, the distant disease-free survival was 87.5 versus 80% with improvement of about 7%. And for the overall survival, there is an improvement about 3.7% at the 3 years. The distant disease-free survival and overall survival were planned to be detected if there is an improvement in the invasive disease survival, which has been proved in the interim analysis. Now, in the ESMO, the extended analysis has been done at the 48 month, and as you can see, there is still consistent improvement in the invasive disease-free survival. It's almost the same, about the 7% in the invasive disease-free survival, and as regarding the overall survival, there is improvement of about 3.4% at 4 years. So still we have the more separation of the curves with the longer follow-up, which is still consistent. The subgroup analysis, the benefit of the olaparib has been observed among the different subgroups. Adverse events, I'll go for grade 3 and more. Of course, it's going to be more in the olaparib group. However, it can, I think, the most common are the bone marrow suppression, including anemia, and neutropenia, leukopenia. Nausea is very high, about the 57%, more than half of the patients experienced nausea, but nowadays I think nausea is a well-controlled disease, and the fatigue in about 40%, only 2% experienced grade 3 fatigue. So adjuvant olaparib improves overall survival at the 3.5 years median follow-up, meeting the significance threshold for overall survival, and the treatment effect was consistent without evidence of significant heterogeneity across major subgroups. And at median follow-up of 3.5 years, effect sizes and absolute differences remain consistent with the previous primary analysis, and olaparib after local treatment and the new adjuvant chemotherapy significantly improved invasive disease-free survival, distant disease-free survival, and overall survival with limited manageable toxicity and without safety signals. Germline BRCA1, BRCA2 sequencing is an important companion diagnostic in breast cancer. However, I think there are still a lot of the unanswered questions for the adjuvant patients. If the patient has a BRCA mutant and she's high risk, she should receive olaparib or she should receive abemaciclib plus hormonal treatment. If the patient did not achieve pathological complete response after and she's triple negative, she should receive olaparib or she should receive the capecitabine or she should receive the combination of both. All of these are unanswered questions, and I think it will depend on the availability of the drugs, the comorbidities, and the expenses of the drug. Thank you very much for being late to us. And
thank you, Professor Dr. Aymani, for this elegant presentation. Thanks for all speakers and attendees. We wish you all the best. Thank you.